Good day, Lermanians. Welcome back to Everyday Health. I am your host, Maverick K. Picolet from the College of Physical Therapy and Respiratory Therapy, and a proud Lermanian. This is a very significant episode because we are celebrating National Hypertension Awareness Month. As we continue serving you a health episode, let us all understand the basics of hypertension, including how it increases the risk of having cardiovascular diseases, reasons as to why self measured blood pressure monitoring is important, and what are the treatment options for people with hypertension. Join me as we dig into a more meaningful and knowledgeable discussion with our guest for today's special episode. The Department of Health, or DOH, revealed that hypertension remains to be a leading cause of illness and is said to be one of the identified precipitating factors for premature death in the Philippines. This afternoon, we have a medical doctor who will help us understand more about hypertension. Let me introduce to you our special guest. He is a former emergency room doctor of Lorima Medical Center, currently a family medicine physician in Lorima Life Check, and occupational safety and health physician of Wholesale, and of course, the school physician of Lorima Colleges. Friends, Armenians, let us all virtually welcome Dr. Jerry Ko.
Okay, thank you, Sir KP, and to all organizers, Ma'am Kim, of this engagement, like the Lorma channel. Okay.
Once again, good afternoon, Dr. Ko.
Hey,
I
good
hope that you are
afternoon.
doing great, Doctor.
Yes, sir. I'm doing great and fine. Thank you.
For your information, Doctor, in our last episode, Ms. Goldmere, my colleague in physical therapy, discussed about stroke and its treatment. And it was mentioned that hypertension is one of the risk factors for having such medical condition. And I believe that there are still a lot of people who are not really aware of the possible effects of hypertension.
Yes, indeed, Sir KP. According to the recent prevalence study in our local setting, the Philippines, some of the medical societies who underwent these studies that roughly 45% of our population has indeed hypertension, and 50% of which they are not really aware of that they have this disease, and 50% of them are really aware of their disease and they are really compliant and adherent to their medication. So indeed, it's a global as well as a local, should I say, endemic. So in our local setting, so it's really the most common non-communicable disease. One of which is hypertension, and the other two is diabetes mellitus and your dyslipidemia or abnormal levels in the cholesterol.
Being said, Doctor, I believe that it is appropriate for us to first define what do we mean by hypertension.
Yes. Okay. Yes, we will define hypertension. Ma'am Kim, can you first show us the slide? Okay, what is really hypertension? Actually, the blood pressure is the force exerted by circulating blood against the walls of the body's arteries. I'm not going to speak here about physiology, physics, the science behind blood pressure, but per se, it's actually the constriction of the blood vessel wall which causes the rise in blood pressure. So blood pressure is written as two numbers. As we can see that there's a numerator and the denominator. The first of which is the systolic, that's your numerator. It represents the pressure in the blood vessels when the heart muscles contracts or beats. And the second, which is the denominator, which represents your diastolic number, represents the pressure in the vessels when the heart rests between beats. Next slide, ma'am. So to further illustrate, we can see that most of us know that the normal blood pressure range is between 110 to 120 over 80 to 90. Some of the guidelines, as we will further see later, because the different guidelines are really evolving year by year. So when we say about systolic blood pressure, like I mentioned a while back, it's a pressure exerted by the blood which is ejected into the arteries, mainly the coronary arteries as well as the peripheral arteries. The normal systolic blood pressure rather is between 110 to 120 millimeter mercury. And the diastolic blood pressure, which represents your denominator, which the pressure blood exerts within the arteries between heartbeats. So meaning to say, it's the relaxation phase of your heart. Now, normally, the diastolic blood pressure ranges from 70 to 80 millimeters mercury or even below.
Okay, doctor, I believe what our audiences need to remember here is that when we say hypertension, there is narrowing or there is constriction in the blood vessels that results into the shoot up or the elevation of the pressure.
Yes, indeed, sir. But this is one of the most common factors representing the pathophysiology of your blood pressure elevation. It's one of the vasoconstricting properties of our heart vessels. Because as we all know, blood pressure, there are a lot of determinants like your pressure, your resistance, and also the capacitance vessels play a major role in the development of elevation in blood pressure.
Being said, doctor, what is the normal range for blood pressure?
Okay. Next slide, Ma'am Kim. So, like I've said a while ago, the blood pressure guidelines is really evolving. So, every 2 years or even yearly, the different societies worldwide will come up with a convention and come up with a blood pressure guidelines. Actually, this is taken from the 2017 AHA guidelines on blood pressure. But currently, we have the 2022 International Society of Hypertension, which uh, uh, which relates the blood pressure guidelines into normal levels and hypertensive crisis. So when we say normal levels, it's the systolic and diastolic blood pressure is roughly around less than 120 and less than 80. As
Mhm.
we go higher, we can see that the elevated blood pressure, we can categorize the systolic blood pressure ranges into 120 over to 129, and the diastolic is less than 80. So, meaning to say, as one blood pressure goes higher, so the risk of other acquiring comorbid conditions will follow. So, the higher the blood pressure, the more risk factor that you would develop. So, especially if you are having diabetes as well as in terms of body habitus when you are overweight or obese, as well as in terms of blood cholesterol elevation. So that would poses a great all-cause mortality and as well as morbidity.
Thank you, doctor. Looking at the table that you are presenting right now, so we can easily tell that the normal is less than 120 over less than 80 because a lot of people, when we take their blood pressure and we found out that their blood pressure is, for example, 140 over 100, and they will tell us, "No, no, that is my normal. That is just my normal blood pressure. Nothing to worry about." But in reality, that is not normal.
Yes, sir. Correct, sir. Because some of our patients actually, when they come to our clinics, we have what we call as your white coat hypertension. So remember that at home, their blood pressure is quite normal, but when they go to the clinics or even in the emergency room, their blood pressure shoots up. So that's what we call as white coat hypertension. So in order for us to understand The blood pressure per se is not equivalent to, for example, in just one sitting, you will label that individual or that patient as having hypertension. Make sure that his or her blood pressure should be it should be consistent. So you have to, in my practice, I usually tell my patients to have a short notebook, a tickler, to measure it upon waking up in the morning and upon going to bed. So I usually follow them up after 2 weeks, and if that's the case, if their blood pressure is in the normal range, then that's good for them. But if not, I have to resort to a non-pharmacological approach or pharmacological approach for that matter. So we will discuss that later on in our as we go along.
With that, doctor, I believe that it is very important for people to really monitor and to document their blood pressure because just like what you mentioned, it is not the diagnosis for having hypertension is not that instant. It will take time and different occasions since it is a chronic medical condition.
Yes, sir. Current guidelines will tell us that there are two forms of really monitoring our blood pressure. We have what we call as your ambulatory and your uh, home-based monitoring. So current guidelines will also tell us that the approved the digital blood pressure monitoring, that's just like the one that we're using in measuring your, in the wrist area and also brachial brachial artery area. So it's there's some of the monitors are really approved. For example, I will not mention the name. So it's one of the most highly sellable products. The brand name. So I will not mention here the brand name. Okay.
Thank you, doctor. We now proceed to the next question. What are the risk factors for having hypertension or developing hypertension?
Yes, indeed, sir. Ma'am Kim, next slide po. So these are the risk factors for hypertension. It is categorized into a non-modifiable and modifiable factors. So we start off with the non-modifiable, meaning to say it's not going to change. It is innate in us. So number one of which is the age. As we increase our age, the propensity to develop hypertension also increases. Another is the sex. They found out that males in young and middle age are more likely to predispose to having hypertension, as well as those in menopausal females because of the loss of protective hormones, as your estrogen. Another is the genetic predisposition, of which 45 to 50% are having higher risk in children with two hypertensive parents. So some other books will tell us that it's really 60%. Once you have your parents, having these hypertensive episodes, their offspring, their children will also acquire it. And another is your ethnicity. So cultural background plays a major role also, as well as your race. So it is found out that it is higher in the Black communities. Now, to the other spectrum, the modifiable factors, which is we can change this over time as long as we discipline ourselves in terms of the following. Number one of which is obesity. We have to also monitor our weight. Number two, the salt intake. We will see later the different non-pharmacologic approaches to lessen or to reduce the blood pressure. Another is saturated fat. Nowadays, since we are still in the pandemic era, so most of us are working at home and we can eat whatever we want to eat. So that's one of the really plays a high role in the development of hypertension. Another is dietary fiber. Sometimes we shy away from eating, for example, your oatmeals, which is really good in curbing the disease entity. Another is alcohol consumption. We will see later what's the quantifiable amount of males and females in terms of alcohol consumption. Stress, well, pretty much the same. All of us are really affected by stress. So this is one of the most common denominator all of us, especially during the pandemic. And physical activity, yes, we need this physical activity, engaging in exercise, whether it's moderate to intense exercise, which really helps a lot in the reduction of our blood pressure. And socioeconomic status also plays a role, like, of course, the different personality types, whether you are working in the office, whether you are a medical doctor or an engineer architect, it's the same thing. The socioeconomic status really plays a role. Okay?
Thank you, Doctor. As we raise awareness on the hypertension, knowing the risk factors are very important so that we can do something about that. For example, if it is modifiable, we can do lifestyle changes or modifications, and it can also be treated via pharmacological management, as you mentioned, which I believe will be discussed further on. My
Yes.
next question, Doctor, is on the symptoms. What are the common signs and symptoms?
Yes. Next slide, ma'am. So the signs and symptoms of having hypertensive episodes is really variable, and it's really dependent on one's individual. So most of us will experience dizziness, whether it's rotatory or non-rotatory. So the feeling of irregular heartbeat, like having chest discomfort at times, feeling of nausea, and sometimes vomiting. For all we know, he's having a heart attack already. So, like I've mentioned, vomiting. Not all vomiting episodes are related to the gastrointestinal symptoms. We can also mask the effect of vomiting whenever we have chest pain, like for instance, having acute myocardial infarction. And another thing is, one of the most common is fainting spells. This is what we call as the vasovagal syncope, or what we call syncopal attacks. The symptoms of which is dizziness, throbbing headache, whether it's occipital or frontal, and as well as low blood pressure can also be a manifestation of having symptoms of hypertension. We will see later what's the link or the intercorrelation between anemia and high blood pressure. And is there such a study, or there's such a evidence-based research pertaining to anemia and high blood pressure? And also, easy fatigability is one of the most common. For all we know that fatigue can really poses a increased risk of developing hypertension.
Knowing the risk factors and the signs and symptoms, Doctor, what could be the possible treatment procedures, management to control hypertension?
Yes, thank you for that, sir. So we have developed a six-step process for assessing a blood pressure management plan. So this step prong approach is usually followed by actually majority of us, the healthcare profession, especially the specialists. Number one of which is obtain a high-quality home blood pressure monitor. So meaning to say, it should be approved. I will not mention the name. The most accurate of which is the one that you're using, the manual type. I'm not saying that the digital type is not accurate, but it poses a 10 to 20 millimeter mercury difference as compared to your manual BP monitoring. Number two, check blood pressure every day or every alternate day. This is one of my practice regimen when doing my blood pressure follow up with my patients. I usually have them present me with the notebook, whether it's in the morning and evening. So I usually get that data so that to compare. So in a day shift or night shift activities. And number three, make an up-to-date list of all current medications. This is the pharmacological part, wherein some of us are really not keen on taking antihypertensive medications judiciously and religiously. So some of which are really afraid they might be having problems with creatinine for long-term medication. So that's a misconception, by the way. And number four, make the required lifestyle changes, as you mentioned, Sir KP. It's really really helpful. It's a non-pharmacologic approach. We will see later what are the different parameters when we're dealing with non-pharmacologic management. Number five, make an appointment with your doctor. This is one of the dilemma of us patients, me included. Sometimes we don't follow up with our regular doctor. We do doctor hopping. That's the problem sometimes because we don't know for sure when to stop our medication or when are we going to continue still our medications. And lastly, plan to follow up on any changes of the plan. This is one of the highlights or the core of the different of the this six-step process for blood pressure management plan. So you should be guided by this six-step process in order for us to have a healthy and fruitful or productive uh, life.
Thank you, Doctor. I would like to make a follow-up question on number three. Make an up-to-date list of current medications and to take them on time regularly. Perhaps one of the most common misconceptions of patients with hypertension is to discontinue once that their hypertension or their blood pressure has already been maintained and resulting to the stop of taking anti-hypertensive medications. What can you say about that, doctor?
Okay, good question, sir. Because most of our patients are like that because they will stop their medication because uh, they know for themselves that if their blood pressure is okay for this day, then they should stop taking their medications. Well, we have this so-called risk stratification process wherein we usually take into consideration the different risk factors. Like, for example, if that patient or individual is having diabetes and other comorbids as well as your increases in cholesterol level. So the American Heart Association as well as other societies develop a matrix plan for them to be guided in taking their medications compliantly. So it's really a misconception for all of us, but according to experts or specialists, that you don't stop your antihypertensive medications, okay? Because it's not only the number that we are dealing with the blood pressure, but the endpoint of which is your heart. So the development of cardiac arrest might still be there. So if you want to stop your medication, and the end complication or the end point will be the likelihood of having a heart attack later on. So I would not recommend stopping abruptly your antihypertensive medications.
Thank you, doctor. My next question is, how can we prevent them of the development of hypertension?
Okay, there's a dictum that we all are familiar with that an ounce of prevention is worth a pound of cure. Next slide, ma'am. So this is one of the most common approaches, the non-pharmacological interventions. No, these are some of the interventions that I've mentioned a while back. Number one of which is weight loss. It's really when we compute for our body mass index, we make sure that we have to get our target body weight in terms of ideal body weight. Remember that the impact, if you are on a weight loss regimen, the impact on your systolic blood pressure, the reduction will be minus 5 millimeter mercury. That's a lot. It constitutes or translates into 20 or 10 to 15% in the reduction or reduction in all-cause mortality and prevent hospitalization. Another is healthy diet, the DASH dietary pattern. What does DASH mean? So it's the dietary approaches to stop hypertension. So remember that it poses around BP reduction of minus 11 millimeter mercury. So just imagine if you are strictly on a diet, avoiding too much meat, avoiding intake of alcohol, or if you are smoking, then the reduction is really that high. Another is reduced intake of dietary sodium. Uh, this is according to the ACC guidelines. No? So another recent guidelines, they mentioned that the optimal goal should be less than 1.2 milligrams per day of sodium intake. So it usually poses a reduction of 5 to 6 millimeter mercury. And another is enhanced intake of dietary potassium, which is really you're aiming for 3.5 to 5 grams per day of potassium intake, which roughly represents a reduction of 4 to 5 millimeter mercury. And another is your physical activity. So according to recent guidelines, you have to resort or engage in physical activity about 30 minutes per day for 5 days. So that's roughly around 150 minutes per week. So it really having an effect on your systolic blood pressure reduction to about less than 10 millimeters mercury. And of course, most of us, I for one, is having moderate alcohol intake in the form of red wine, not to mention other brands, right? Like your whiskey and brandy. So it's but common for us, just to distress a bit whenever we finish our work at the end of the day. So not that much, because it poses really a harmful or deleterious effect in our body. So if you follow the reduction of alcohol in men, less than 2 drinks per day, and women less than 1 drink per day, then the impact of your systolic blood pressure in terms of BP reduction is roughly around 4 to 5% millimeter mercury. So these are one of the most important, significant non-pharmacologic interventions being employed by most medical doctors as well as specialists. I'm not here to
So,
discuss the pharmacological treatment because it's really very uh, uh, a very elaborated pharmacologic therapy, because some of which different guidelines, different treatment regimens in terms of their mechanism of action. So I will not dwell on that.
yes, doctor. So these non-pharmacological interventions, as we realize, they can directly address the modifiable risk factors for having a hypertension.
Yes, indeed, sir. Because if you are going to follow these interventions, and to be honest, according to some of the studies, evidence-based and meta-analysis studies, if you follow these non-pharmacologic aspects, then the BP reduction will summate to more than 30 to 40% in in preventing hypertensive mortality, or for example your heart failure, your chronic kidney disease, or you even diabetic, the onset of macrovascular and microvascular complications of hypertension, as we all know.
Yes, doctor. Perhaps one of the most common questions of our audiences or our patients is that what will happen to them if blood pressure or high blood pressure is not well maintained into a
Yes.
normal range?
Okay, good question, sir. Uh, like I've said a while ago, we are not only treating the numbers of the blood pressure, whether it's numerator or the denominator. The real essence of which is you have to treat the progression of the hypertensive complication. So I will illustrate further. Next slide now. So this is just a summary of the preventive aspects of curbing the onset of having hypertension. So we have discussed stop smoking, reducing stress, doing exercise regularly, eating a healthy meal plan, losing weight, cutting down on caffeine, limiting alcohol. So next slide, ma'am. So before we go to that question, sir, I'll just illustrate some of the non-pharmacologic interventions in terms of dietary plan. So these are the 30 top blood pressure reducing superfoods. We all know that pineapple, bananas are there. This is quite common in our setting. So if you are eating bok choy as well, the one that we are using in the sinigang or in our bulalo. So it's really helpful. So as long as your salt intake is really to a lower level. So another is alkaline water. Watermelon is really it will help a lot in preventing hypertensive episodes. Dark chocolate and so forth and so forth. Next slide, ma'am. Okay, this is what I've mentioned. I will like to mention, Sir KP, the complications of hypertension, the 5 C's. As we all know that hypertension per se is not only pertaining to the heart and the lungs. It's really a multifactorial organ disease. So one of the most common of which is the first C, the coronary artery disease. What happens to coronary artery disease? It can lead to the narrowing of blood vessels. So in short, it's a property, what we call as your vasoconstricting property, to block the normal blood flow to the coronary arteries as well as other tributaries. Number 2, chronic renal failure pertaining to the kidneys. So remember that we only have 2 kidneys, of which it can, in terms of cardiac output, they can deliver up to 25% of the blood supply. So if the small blood vessels in the kidneys are damaged, and your kidney function might be affected. So that's why we always request for blood creatinine and as well as your blood uric acid. Another C is your congestive heart failure. So pumping blood against higher blood pressure in the vessels causes heart muscles to weaken. For example, is your cardiomyopathy, wherein the muscle fibers in your heart is really thickened and enlarged. So that's why we develop left ventricular hypertrophy, progressive heart failure, and so forth. Another is if left untreated, unchecked, your uncontrolled hypertension can also lead to cardiac arrest. So whenever high blood pressure can cause CAD, damaged arteries cannot deliver enough blood to other parts of the body, eventually to heart attack. That's why this is one of the common endpoint when treating your hypertension. That's why we have to educate and tell our patients to not stop taking their antihypertensive medications. And lastly, cerebrovascular accident, or what we call the stroke, can also develop as a complication of hypertension. Particularly the large arteries in the brain can also lead to vasoconstriction. So impeding blood flow to the brain causes anoxia or deprivation of oxygen.
Thank you, doctor. So those are the most common complications when our high blood pressure is not controlled. So it is very important, again, for the control of hypertension and to continue taking antihypertensive drugs. Doctor, my final question for you is there a correlation between anemia and hypertension?
Yes, sir. There's next slide, ma'am. Okay. This is a summary of complicating uncontrolled hypertension in terms of their number 1, there in the upper portion, right upper portion, disrupted blood supply to the brain can lead to stroke or dementia. Another is hearing loss tinnitus can also mask the effect of having hypertension or uncontrolled hypertension. Another is kidney failure, and another is vision loss. That's one of the most common microvascular complications of hypertension. That's your retinopathy. blurring of vision, complete loss of vision. Another is coronary artery disease, like I've mentioned, enlarged heart, and your heart failure, and reproductive system. Sometimes there's poor sexual dysfunction, or there's abnormal sexual dysfunction. And in terms of libidinal drive, so whether it's the male side or the female side. Next slide, ma'am. Okay, to answer your question, Sir KP, this is one of the most common question, no? As regards the different webinars I've attended. So most doctors will ask this, that, but according to some research, does anemia ameliorate or worsen hypertension? There's no consistently observed link or relationship between levels of hemoglobin and level of blood pressure. But through over time, blood pressure can propagate the development and progression of kidney disease. So in terms of your hemoglobin level, you should to also check and balance your hemoglobin levels. For all you know, that you are having already anemia of chronic disease. That's why there's no consistent evidence-based guidelines or medicine pertaining to the interlinkage between anemia and hypertension, except for anemia of chronic disease that can progress to chronic kidney failure. So presence of high blood pressure should not preempt correction of hemoglobin levels. So this is a different two entities. So we have to be guided that we have to control our high blood pressure as well as your hemoglobin levels. So we have to really, it's very important for us to monitor blood pressure during follow-ups and make necessary pharmacologic adjustments. So that's why whenever we follow up on our patients, worth noting that they are already on their antihypertensive medications. It's for us to say to them that either we lessen the dose or increase the dose or add another drug regimen to further reduce their blood pressure, because we are treating not only the blood pressure number but their progression to either heart failure or to the risk of having heart attack later on, to prevent hospitalization. That's the key essence of that. When we are adhering and complying to our drug regimen.
Thank you, Doctor. Before we finally end our episode for today, are there still things you would like to add or message to our viewers?
Okay, so really, hypertension is, like I've said, one of the most common non-communicable disease. So, in fact, this is one out of three. Basically, we are seeing during our annual medical examination to different employees, no? So, the other two will be diabetes mellitus and dyslipidemia or abnormal blood levels. And on that center is the risk of having risk of overweight or obesity. So indeed, the key message here is, number one, we have to really know or be aware of our risk factors. Number two, we have to take into consideration the symptom control. And number three, we have to resort to non-pharmacologic interventions, like I've mentioned a while ago, like engaging in DASH diet approaches, stop smoking, reduced dietary intake, alcohol consumption should be lessened, and also cut down on salt intake, and also engaging in physical activity, 150 minutes per week. And another thing is, in order for us to understand that the main role or the main endpoint of having compliance and adherence to drug regimen is really preventing all-cause mortality and prevent hospitalization. So with that being said, thank you very much for this opportunity, and I'm looking forward to another series of everyday health. Thank you.
Thank you very much, Dr. Ko, for our very comprehensive, informative lecture type of interview today. We really appreciate your time spent with us amidst your busy, hectic schedule. Thank you very much, Doctor.
Okay, thank you, sir. Thank you.
There you have it, friends, Lermanians. Join us again for our next healthy episode with our Lermanian experts, only here at Everyday Health.